morning, respected dignitaries on the stage, faculty colleagues and residents. So after 4 days of exhaustive academic discussion, let's have a discussion on this sideline topic also. It's very relevant for newer institutions, for young faculty. Uh, I am Dr. Vijay Kundal and
I'm Dr. Enono.
we both will be moderating this. Along with us, our expert moderators are Dr. Roshan Chanchalani, Additional Professor, AIMS Bhopal, and Dr. Sunita Singh, Associate Professor, AIMS Raebareli, Dr. Shubhalaxmi Nayak, AIMS Jodhpur, Assistant Professor. And we have our experts also, Professor Satyashri Madam. She needs no introduction. She's a HOD Pediatric Surgery at AIMS Rishikesh. Dr. Ashish Chabda, Professor and Head, Guru Gobind Singh Medical University, Faridkot, and Dr. Shashank Shekhar Panda, Additional Professor, AIMS BB Nagar. So we'll be just giving few overview of this. So what is expected from a faculty member in medical institutions? Teaching, mentoring of students, communications, student support, professional development, institutional collaborations and research. And this is what our National Medical Commission also recommends to improve the quality of teaching and reduce gaps in learning and make conducive environment for teachers. But faculty at such institutions encounter a unique set of challenges which affect the quality and delivery of surgical care, including infrastructure limitations, staffage shortage, lack of specialized equipments, procedural inefficiencies. So, specific to pediatric surgeons, what are the issues being faced? They also include inadequate infrastructure, limited staffing, shortage of specialized equipments, insufficient training programs, delayed setup of diagnostic facilities, administrative delays, lack of pediatric focused policies. Inadequate infrastructure means newly built hospitals may lack fully equipped units, specialized operating rooms, ICUs are pediatric friendly recovery areas, and limited staffing also, few of the nursing staff, specialized unavailability of specialized anesthesiologists and specialized equipments also. So let's have views from our moderators. What are the key infrastructural and manpower challenges you face, and how do these impact your ability to operate effectively? Dr. Roshan and Dr. Shubha. Please.
Thank you, Dr. Vijay. So infrastructure wise, since we have started the department in 2017, we have sufficient OT, we have our ward, but the number of beds is a limitations. We have only 20 beds and only 8 beds for NICU and PICU. So looking at our workload, these beds have a limitation so that we cannot accommodate too many patients at a time. We have 6 OTs running, but on a single day we have 2 theaters. So discharging the patients and admission of those patients on those particular days becomes a problem. And since our pediatric medicine and surgical departments are running since 2012 and 13, so sharing the beds remains a challenge. So in my point of view, though we have our modular theater and ward and NICUs and PICU, bed is a big limitation.
I would want to extend that to the manpower. It comes down to nursing staff, technicians, and sometimes even the residents. Even though we have, sometimes we have adequate number of nursing staff, especially in the wards and in the NICUs especially, they are not trained adequately. They have no idea how a small baby needs to be catered to, the IV access, the finesse required for that is not there.
So can we have remedies or solutions from our experts? Dr. Ashish.
Good morning. Regarding the infrastructural anomaly remedy, I think one of the factors which should be included that whenever the new buildings are coming up or the new buildings or new departments are coming up, the concerned specialist doctor should be consulted because only he or she knows what are the needs which they will have further when the department is set up, how many OTs are required, how many faculty rooms are required, how many SRs or JR rooms are required, and even I am working in a government setup. To my surprise, I don't have any separate male or female room, senior resident room. So these are the factors, and these factors should be kept in the mind whenever the new biddings are coming up. The concerned consultant should be there in the committee. That is one thing.
Yeah,
In,
ma'am.
in fact, I feel that after coming here, this is a very new place for us. Earlier, though it was started by Dr. Intezar, he was only part of general surgery. Very recently, it has been, a pediatric surgery unit, maybe from the last 8 years. That's all. We faced innumerable problems. And the remedy is only that we haven't been included in anything. We didn't have a say in infrastructure. We didn't have a say in the manpower. I mean, the nursing officers who have been taken don't know a bean about anything. And they are being transferred every 3 months at the whims and fancies of the administration. How do you run a department? We have 20 beds, like he said, because these are the newer INIs. There's 2-tier, second-tier INIs. And what do we do about it? Where is the finance? We are not member of any committee here when it comes to the finances, in the procurement, in stores. So we would want everything like this. I think if you want to develop the departments, it's not only pediatric surgery. As such, for the development of the institute as such, for any clinical department, it's mandatory that the faculty, the HODs are taken into consideration, and the HOD has to be given due powers and due importance, not just a figurehead sitting in the offices, please.
Thank you.
As a few of the faculty, there are 1 or 2 faculty in new institutions. So what can individual do? What can a young faculty do? Dr. Shiva.
Our department started in December 2022. Initially, we have only 2 faculties. We have to do everything, work up of patient, operate the patient, and also look after the post of patients. Then we decided to take the non-academic JRs from the common pool. Because I am in the mainstream of the administration, I have few important posts in the administration in our institute. So I took 2 non-acad JRs from the common pool. Then I took 2 senior residents from the general surgery. After that, the running process of our department became little smooth. Then we planned to start the MCS, and there are 2 types of courses, as you know, 6 years and 3 years program. As ours is a new institute and the patient load is not that much, so we discussed with our director and started the program 6-year MCS program. So gradually we increase the manpower. That should be the motto of every new institute, because the nursing manpower is always plenty. But the resident manpower and the faculty manpower, you have to plan accordingly. And the faculty manpower, you cannot increase overnight, because it requires the permission of the PMSSY and also the Department of Expenditure. But by little bit of effort and also by administrative policing, you can increase the manpower in your department by taking it from the general surgery and the common pool of non-acad chairs.
Thank you all for your expert opinions. A quick tip from anyone from the crowd. Can we have someone who has... Yes, Dr. Intezar, please.
Yeah, I joined the AIMS in Rishikesh, I think in 2012 in December. And AIMS Rishikesh started in July 2012. So I was all alone for first 5 years. The main problem is not the system, or the main problem is we all, including me, because we always complain. Don't complain. Be a problem-solving person. Try to solve the person. Come with a solution. Go to your director, go to your MS, go to your dean with a problem, but along with there should be a solution. This complaining is not going to solve any problem. Your department is there or not there, you are working or not working, it doesn't matter for director or for team. Okay, and second thing, you have to come out of your comfort zone. If you want, I want to work like a full-blown department. I will take 1 round, and no round is not possible. When I joined the institute, I used to take 4 rounds per day. 1 in the morning, 1 in the evening, 1 in the night, 1 in the late night, because I was all alone. There was no resident. Now we have a comfort zone. We have residents, we have junior faculty. I take only 1 round, and sometimes I don't take in any round, because they can take care. So two things, be a problem solving person and you have to come out of your comfort zone. Everything is there. We have a good fund. Very good people are sitting on the director post, dean and MS post. They will always support you. If you will show them, yeah, I am doing the work. If you want a comfort zone, no one will support you. Finish. And don't be a complaining person.
Enumerated and also the solutions that have been given. Moving on to the next question, are there sufficient, can we have it on the, yeah. Are there sufficient training and development programs for staffs, including specialized support of pediatric surgery residents? I would request Dr. Sunita to opine on this question.
As such, there are no training program defined by our association or as a department level. But to solve the problem, I usually involve the approach to the hospital infection control committee of the institute that and then insist of them to be conduct a frequent training sessions for the nursing officers. And also the hospital administration services are there. They used to help us in making the digital system, how to we facilitate the digital system, digital registration, digital prescription, and then the digital discharge, everything they used to facilitate. Then I used to also involve the pediatrics people. So the general procedure like PIC line insertion, central line insertion care, my as such I don't have resident, but whosoever JR academic or non-academic join, I used to send them for their training session. It is not like that my OT is that, so I will engage that JR with me. I leave him to go and attend the session. And then another thing is that the instrument care and the maintenance, the whatever company supplies us the instrument, they have the clause that there should be training sessions and we have to poke on them frequently so that our OT staff used to learn that how to care the instruments. These instruments supplied once and once damaged, and the repair is almost impossible. It takes a lot of time. So that I used to do. Other suggestion.
So what you're saying is that there are no particular pediatric surgery, maybe developmental programs, but what the institute is offering, you try to grab those opportunities, right? So I would, as an expert, can Dr. Panda opine on this?
I think in all new AIMS and AIMS New Delhi and other established institutes, there is a robust training program and development program for all faculty members, residents, and nursing staffs. And for the development and training of the faculty, it is not difficult because you can hire professors and trainers from the other institutes and also for the residents. Problem lies with the nursing officers because the entry level is nursing officer and after 3 years they will become the senior nursing officer. And if we are planning for a pool of nursing officers, they will work in your NICU, PICU or in OT area. You have to send them to recognized institutes where the NICU, PICU and OT are running for years and they have a training program for the nursing officers. That thing we are following in our institute. And second thing is the frequent change of roster of the nursing officers that should be, I think, decreased to at least 50%, so that 50% staff will stay in NICU, PICU or OPD area to smoothen your process of running the facilities.
So just to, want to add on this, at our mic.
Hello?
Yes, just want to add, at AIM Jammu, I think possibly the only AIMS where nursing staff 6-month training was conducted at a mental institution in AIMS Delhi, and for faculty also they sent it for 2 weeks, and otherwise also regular faculty development programs are being conducted there. So we'll move to next question.
Dr. Vijay, once. Just adding one point.
Yes.
I think if we are sitting in a remote hospital, like me, I'm sitting in Faridkot, I'm working there. It is one of the remotest area in Punjab. We can send our nursing officers or even the resident to some other higher centers, already established center. We can have collaboration, like we have PJ in our area. So that is one thing we can also consider. That is one of the remedy.
Move to the another question. What are the key equipment related challenges and which specialized equipments are available? One of the important question. This question is for Dr. Shubha. Dr. Sunita.
So instrument related problems are a lot. Even after 4 years of starting the institute, there are no open surgical instrument is still delivered. Our new institutes are born with the DPR items, born to be follow the DPR items, and these companies are not delivering instruments on time. We are and even we don't have direct connection with them. So we have to go again and again to the administration, and still date there is no bronchoscope, no neonatal cystoscope on the and this IGS system, 4K system. All these are far beyond from our approach currently.
What is being done to get these, or what is being done?
Just go to the administration and then write, repeat and repeat reminders. To solve the problem of open surgical instrument, I used to purchase in a small parts like hypospedia set, thoracotomy set, laparotomy set. By small frequent amounts, I have purchased around 25 lakhs instruments till date in the 50 years, and started OT with my own instruments meanwhile.
Dr.
So
Shubha.
I come from an absolutely other end of the spectrum. We have all the specialized facilities at our institute. We have advanced laparoscopy, we have advanced thoracoscopy available. We have facility for 3D, we have facility for ICG and fluorescent guided surgery. Not just that, we also have anal manometry, we have urodynamics, we have all the state-of-the-art facilities available at our institute. But again, we also face problems because they have been there earlier. The new requirements are not being fulfilled.
Our comments from expert Satishi, madam.
I also come maybe a little level lower than Shubha, but we do have quite a few equipments that had come earlier when the department had just started. But whatever came, and then there has been a stop. And then now we are finding it very difficult to get the old ones repaired because it's already 10 years more than that and almost to the stage of condemnation. And getting new ones, it's a horrendous task for us.
What I want to say on this topic is regarding the equipments for in our institution. We were getting most of the equipments from government procuring agency through DPR, and what they are not delivering, we are getting it through the either local purchase or through the GEM or through the global tender. So what is important to mention here is this knowledge of procurement and purchase related process are very, very important for the younger faculty or for the younger people also. Even it should be, we should train our residents also in this.
Yeah. Can I make a comment?
Yes. Please.
Yeah, please.
Yeah. So what you said right now, I wanted to highlight that it's not as if you join a completely running department, it's good. But if you join a department when it's developing or you are procuring stuff and developing specifications, it's a big plus actually. Like I joined SGPGI 10 years back, like our department is 15 years old. And I made a lot of specifications and was part of the procurement process, you know. So now most of us who are part of that team know what equipment is there, what are the specs, when it breaks down, how to get it again. So that is a very important key aspect of being a faculty in that institute. So being a part of the team which procures stuff and makes specifications, I think that should be part of the faculty development.
Yeah. So
Yeah.
to summarize it, we do have unpleasant feelings with regard to the procurement and the other issues, but there are positive things that we have to change our attitude and see to it that learning is there in every procedure, right?
Dr. Vijay, just a brief comment. I think that procurement is one part which is important, but the most important part is the managing the instruments, their AMCs, CMCs and all. So that, like if we are one or two faculty, we cannot, of course, we cannot take care of those things. In that case, what our institute has done, we have hired a third party. It is HLL Life Care. It is a government company which will deal with the instrument companies directly. So it is a third party. We have give, like we have given a list to them, like these are the instruments, this is the AMC, CMC, so they are going to take care of the
Thank you,
instruments.
sir. We'll
They're-
moving to next
That is a
question.
third
Because
party.
shortage of time. Thank you.
Dr.
Yeah.
Kundal, can I make a point here?
Please,
Yeah,
just short.
Yeah, very pertinent small point. I thought there's a IGOT Karmyogi app available recently launched. This would be very important for the faculty members, young or otherwise also. There are modules in it to get used to the format of how to purchase. And there are other modules
From the
also.
Ministry of Health only.
Yes,
Yeah, yeah.
exactly. And it is mandatory now, so it's better to complete that and keep revising it. And use it at your, which component is useful for your particular area, and then you can always improve.
Thank you. Thank you.
Coming to the next topic, subspecialty development, either in the form of clinics or developing an interest as a young faculty. This question I would like to put across to all the three moderators, Shubha, Sunita, and then Dr.
Just short
Roshan.
comment, please.
We do not have any specialty clinics as of now, ma'am. It's in the pipeline.
I started the pediatric urology subspecialty clinic, and then the multidisciplinary clinic of antenatal detected anomalies, and then order recently come from the Ministry of Health and Welfare regarding the setting up of hypospadias clinic. So that clinic is automatically established in my department. For other two clinics, I have to work very hard, right, multiple times for the getting the approval. And the idea behind was that so that I get the pediatric urology patient, otherwise there is always conflict with the urology and pediatric urology. So SFU fellowship helped me in making the base for that, and then I get the approval. I am running the clinic. I have some basic pro pharmas to be filled regarding details, but the problems against came that pro pharma is not completely filled. Even after sensitization of nursing staffs, they are not completely filling the data.
Okay.
So I recently requested the administration to make the digitalized data storage system to
Okay.
procure that, so that at one click I could get the data, and whenever needed I can.
Okay. So you're thinking you have about 3 subspecialties which you have been able to, give this thing.
Small
already
comment
to-
to make.
Yeah, Dr. Roshan.
Since our pediatric department is 10 years old, we luckily have a pediatric nephrologist and then a pediatric oncologist. So what we make sure is that we run 2 clinics, urology and oncology, and we make sure that it is run on the same day. It's run on the same day when the oncologist is available or a nephrologist is available to share the patients on the very same day.
That's a very good.
So continuing with the same question, how do you get support from neonatologist or anesthesiologist in patient care?
Ours is a well-oiled engine, sir. We have a very good pediatric medicine department also. So all our CKD patients are attached to the pediatric nephro clinic. Most of our empyema patients come from pediatric pulmo medicine. So in that way, we have a very good system in place. Our only shortcoming is a pediatric hemato-onco department. So most of the solid tumors we are dealing on our own. The chemotherapy is being provided on our own. But otherwise, we have a very well-established system.
Regarding pediatric anesthesia, there's always a problem with anesthesiology. So you have to be compatible and friendly with anesthesiologist. The cases you are posting, especially the long cases, you have to show them beforehand so that they don't cancel it on the next day. The timing should be perfect, like the time which you give them should make them comfortable. You show your results to them, involve them, have regular meetings with them. Only then you can have a good rapport with pediatric anesthesiologists. You can make them as a co-guide or you become the co-guide in their thesis. So this is how you have a licensing with pediatric anesthesiologist.
Any short comment from experts?
From our institute, I I really don't know. It's okay, I would say. It's how you go about being friendly with them. After all, that forms the baseline. Otherwise, it's quite difficult for us.
Okay, so the next question is, the current status of research in your department, how well is it integrated into daily activities? What are the key barriers that you are facing in conducting researches? And the support that is needed to overcome them, yeah.
Again,
Shubha
us
and-
being a fairly adolescent institute, We have very good number of residents. We have very good number of their theses which are in place. We have good number of intramural projects and some extramural projects also going on. We have the necessary armamentarium for it, but our shortcoming is the number of patients. All our research are in place, but again, the sample size is not adequate to give us a very good statistically significant result. So that is our main barrier, and also some amount of funding is a problem. Getting exclusive pediatric surgery funding, unless collaboration with another department or another institute, is very difficult.
I was facing the same problems. My many studies were turned into the pilot studies. Then I have to do something because the promotion should be there. So I took the basic surgical, basic research as in my research topic, and I have the 20 lakhs around funded projects. But these are still, I am working a lot on it, but these are still counted as a non-surgical projects, like basic research of infection, that's all related to some drugs. So this is a problem, and for if IAPS can do something in it, there should be any collaboration between the institute, because MOU, it is not possible for me to run for MOU with the other institute for the collaboration. If IAPS can help in it.
One short comment from Dr. Panda. What more we as a faculty should do to involve research into our department?
As the theme is for the junior faculty, I'll mention here the Sneha Bhargav committee report. According to that report, all the faculty members in the clinical department, whether from the professor head or the assistant professor, should dedicate 30% of their time to the research. And if you see the APS criteria for the promotion, in assistant professor level, you should have at least one intramural project, 2 to 5 lakhs. So at the institute level, you should persuade your director or the dean research to at least grant 2 to 5 lakh project to all the assistant and associate professors, so that they should have at least one project to become eligible for the APS. And similar thing is for the associate to additional promotion also. And the barriers usually we face in the new institutes, that sometimes the fund for the intramural project is not sufficient from the institute level. So if the association or we can collaborate with other institutes, that is a very big question.
Thank you. Because of the shortage of time, we'll move to the next question. How about imparting administrative duties to clinicians? For those clinicians who are already in administrative work, how do you manage both administrative and clinical duties? One of the tricky question. Dr. Roshan and Dr. Sunita. Short comments, please.
Thank you for that tricky question. Actually, it's playing a very big part in our daily life. It is a double-edged sword. It has some advantages. It has some disadvantages. Advantages are like we have a say in our institute once you take up any administrative duties. Like I am in charge of the entire pharmacy of AIMS Bhopal. I am in the MOU committee. I am in the hospital procurement cell, and so on, so on. So once you are office bearer of that committee, you have a say in the department. People listen to you. The disadvantage would be you have to devote practically every afternoon to one or the other meetings. You have to sacrifice your class. Even you start your day at 8 a.m. in the morning, you finish at 8 in the evening, and the day is still not finished. So there is always, you have to keep a balance between the administration and the clinical work.
So, any comment from experts?
Well, since I'm at a senior level and there's so much of administrative work for me, I would definitely say, initially before coming here, I knew mostly about PGI because I'm a PGI graduate, but the INI system of working is very different, and I learned it from scratch. I worked hard for it, and I would definitely advise the youngsters. We have, of course, given a lot of administrative responsibility and categorize them at different levels to different, associate professors, assistant professors. They need to learn. It's very important as they climb the ladder. It's just not clinical work alone.
Yes. Any comment from audience? Vijay sir, what some comment?
I won't take much time, but I would like to share. It's my 20-year journey in a government department, which started as a unit and was doing pediatric surgery for almost 40 years by Professor Raina, who was my professor there. But when I reached there after completing my MCH, we started with a handheld pulse oximeter, only one in the department, no radiator, nothing, radiant warmer, nothing, no ventilator, to today, we have 10 ventilators, almost 60 pulse oximeters, 3D laparoscopy system, STOS system, 2 laparoscopy system, all urology equipments, 2 4.5, 6.5 cystourethroskop, one video so I'm not boasting my department. What I'm wanting to say here is it's a long journey. It's a long, continuous journey. Roshan is witness to it because he joined as my assistant for professor when I was associate professor. We worked hard together for that. So that is one thing we should not give up. It is a continuous journey, madam. Takes little time. You keep on doing. Second, head of the department has to be very proactive. And he has to do a lot of shitty work and go to administrative offices off and on. We should not crib about it at all. And whatever shitty work we get, we should do it very proactively and very proudly and very nicely. Faculty, next to the HOD or junior faculty, should always accompany head of the department. Because I used to accompany Rana sir and I learned a lot of tricks of the trade of that particular arena. There are different tricks there. It's not about like chamchagiri or something, but there are tricks. You have to please your dean, keep him happy and get the job done, or director. Second, you should assist administration in all the activities of which are not department related activities, they're institutional activities. So when you do for them, then in reciprocation, it increases your bargaining power. So whenever fund comes, you can like, sir, pediatric surgery ko ye chahiye. That's how it is possible. Always be in government committees like kitchen, laundry. I have done all tenders. See, if you ask me, like I know all the tenders, kitchen, laundry, safai and everything. You ask me, I have all documents with me. Roshan knows that very well. I am like an encyclopedia of these tenders and all. So this is important. Grab an opportunity to showcase your department work. Even smallest achievement, showcase in your groups so that everyone knows, oh, this department is doing very good. This department is some platforms are there where IAS reaches there. So it should go to IAS. Newspaper is one of the best things because they like to listen to good things about institutes. So paper mein aayega to IAS get impressed. They increase their scores. You don't get anything. But after 5 times he says, no, pediatric surgery demand is there. Okay, give them. They are doing good work, na? So this is very important. Your department should be poster boy of the institute. And it is a continuous process. Keep working hard. Nothing more to say. Failures and success are part of life.
Thank you, sir, for your valuable comments. Just short IAPS survey, which was conducted by under the IAPS banner.
Very briefly, just 2-3 slides. We had about 50 responses to the survey that we had sent across in the group. And to our surprise, not our surprise, but you can see that the response was mostly from the newer institutes. About 67% was from the institutes which were less than 10 years. So this is a little close to the topic that we are discussing today. Are there adequate pediatric surgery resident support? Definitely, it looks like 50 is a good number for support, but the other 50 also says that we do not have the enough support. Who does the duties to cover the PGs? We know that the residents are doing, but we can see in the red spot that almost 53% of the assistant professors are also the first line in doing duties. How would you rate the overall infrastructure of your department? Yeah, a good percentage of the people are happy, but there are almost 40% who says that it needs improvement or it is poor. What are the key infrastructural challenges you face? The maximum that's taking the space here is inadequate space and lack of advanced diagnostic instruments. How much ORRs are you able to get in a week independently? So the maximum that goes is a junior faculty is doing less than 10 hours in a week. Is the current manpower sufficient for your department's needs? 70% says no, the manpower is insufficient. And the maximum manpower that is lacking is the inadequate support staff. What are the key equipment-related challenges? The first two, insufficient number of machines, and number 2, the frequent breakdowns. Which of the following equipments are available in your department? It was good to see that almost 96% has pediatric laparoscopy set. How well is research integrated into your department's activities? 48% says very few research initiatives. And what are the main barriers? Number 1 is limited time due to clinical workload, and number 2 is lack of funding. Thank you for your patient listening.
Thank you for patience hearing. Last closing comment from expert Satyashi madam.
Well, overall, I think, I don't know whether we're only discussing about the INIs here because most of the experts sitting here are the INI people, but it would be nice next time to get onto the platform, even the private people as well as the corporates, and if somebody is working in their own nursing homes, to be on this because it's important to know how they are facing their problems because we are all in the government sector and we know how the government sector works. You know, and like Intezar says, no cribbing, but then there is more of cribbing anyway. Because we, even though we go with solutions, they always smile and give you a cup of green tea or tea and say, yes, ma'am, yeah, we'll do it. But then, does it really happen? Is the question we need to ask. And how much longer are we supposed to be struggling like this? How much harder are we supposed to work? How much low can you bend?
Okay, thank you to all the moderators and the experts. Thanks for joining us.
I suggest all the, moderators to publish this survey in the JIAPS. So we have done very good surveys. I mean, this good information should get documented somewhere.
In fact, our request is we have only 50 responses, so we'll be glad if
Why not?
those people who have not responded,
We can still upload the
yes,
survey
we
and
will,
get more
we will
responses.
circulate the survey.